Thank you for the invitation to give a few comments on what I thought the highlights of the EHA or EHA, depending on where you're from, people say it differently, meeting in 2023 were. My name is Dr. Gail Roboz. I'm a professor of medicine, and I work at Weill Cornell Medicine and the New York Presbyterian Hospital in New York City. I run the leukemia program, and it's really my pleasure to kind of offer a few comments on this very important Congress. So AML has been an exciting and evolving space. Once termed the land of the lost, acute myeloid leukemia, a dangerous and aggressive form of acute leukemia, was really besieged for so many years, with congresses going by without terribly much to offer for patients. And over the last several years, this has changed very dramatically. And what we've seen actually is that each one of these important international congresses has practice-changing content and new things for clinicians to offer their patients. So one of the very exciting areas has been the application of targeted agents to the backbones of chemotherapy that were for many years really all we had as staples for AML treatment. And that era was really ushered in by a well-known international trial called the RATIFY trial, which demonstrated that there was an overall survival benefit when the FLT3 inhibitor midostaurin was added to a conventional backbone of chemotherapy to AML patients. And this sort of the identification of molecular genetic abnormalities that characterize AML and the subsequent targeting of these abnormalities has really changed a lot of the field. And FLT3 is an important driver mutation in AML. Again, RATIFY leading the way to us understanding that a specific targeting of the FLT3 mutation is offering benefit to patients. And this was followed by the approval of other FLT3 inhibitors. And the one that I'm going to talk about now is called gilteritinib, which was initially approved for patients with relapsed and refractory disease. It's a well-tolerated oral therapy and actually beat chemotherapy in the treatment of FLT3 mutated disease in relapsed patients. So offering those patients cycle after cycle of chemotherapy really doesn't get anywhere, whereas gilteritinib alone offered a benefit, resulting in its approval. Now, this has led to the wider application and study of gilteritinib in other aspects of what patients and some doctors will call the AML journey. And the specific trial that I'm talking about from EHA was the MORPHO trial, which looked at whether or not gilteritinib would be of benefits to patients with FLT3 mutations as maintenance therapy after stem cell transplantation. This is always a shock to patients who are undergoing allogeneic stem cell transplantation, which is really our curative therapy, our only known curative therapy for AML, that they sort of can't believe that after undergoing a transplant, they would still require some maintenance. But it has really become practice, based on limited, sort of not perfect data, to offer a FLT3 inhibitor to patients once they go into remission after their stem cell transplant. And this was a randomized trial that actually didn't meet its initial endpoint of relapse-free survival when compared to placebo, which was initially viewed as sort of an alarming result of, well, maybe we don't need to use gilteritinib as post-transplant maintenance. But actually, the data presented at the conference were specifically looking at trying to identify the patients who really would benefit from the drug. And what's very clearly shown, and what was presented by Mark Levis from Johns Hopkins, was that in the MRD positive patients, or patients with measurable residual disease, there actually was a very significant benefit of gilteritinib in eradicating what looked like residual clones or potentially rising clones of disease that persisted after transplant. So this is very important because, first of all, I think people tend to run and dismiss trials quickly when the initial endpoint isn't met. So it's, oh, it's a negative trial, forget it. And that doesn't allow the investigators enough time to really process the data and use the data optimally. And in this case, what the trial was intended to really show is who are the patients for whom gilteritinib post-transplant maintenance would be of benefit. And this absolutely did show that for MRD positive patients, there is a survival benefit for gilteritinib, and I think that this will be practice changing. What's also incredibly important is the demonstration of the benefit of MRD monitoring in this setting. And for FLT3 mutated patients initially, it wasn't even really clear that monitoring residual FLT3 was going to be of benefit or help. And here, the specific next generation sequencing based MRD assay was really very, very important because it identified the specific subset of patients for whom post-transplant gilteritinib would matter. And I think both the assay, the practice of assessing MRD, and the subsequent application of therapy are going to be very helpful here. And I think what it's doing is allowing doctors to use the medication on the patients for whom it's benefiting and have those patients who don't need it, i.e. who are MRD negative by this specific next generation sequencing based assay, to allow them not to have to go on medication. And I do think there's going to be some learning here because not everybody has access immediately to this particular MRD assay. So I think that is going to become more common and widespread, just as initially FLT3 mutational testing wasn't commonly available and widespread, and now it is really worldwide. And the access to FLT3 mutational testing has grown, and this has been shown in a number of studies throughout the world. I think the same is going to happen for the MRD assay as well, because it is allowing docs to discriminate which patients will benefit from a specific agent. Now, keeping with the theme of targeted therapy, so again, the identification of genetic abnormalities, mutational abnormalities that characterize AML and are associated both with prognosis and with different therapeutic options has changed things. And a specific target that we have been very interested in is NPM1, because NPM1 actually affects a lot of AML patients, depending on which study you look at. It can be over 25, over 30, sometimes over 40% of patients. I mean, it's a high unmet need in that it affects a lot of people. And the NPM1 mutation is sort of maybe mischaracterized as quote unquote favorable, because on the one hand, it is a mutation where for some patients in the initial setting for upfront disease, we can get away without stem cell transplant in first remission. But still, many patients with NPM1 abnormalities relapse with their disease. It looks like their initial duration of remission, if they get into remission, might be a bit longer, but there are still many relapses. And not only that, with relapse disease, the outcomes aren't good at all with overall survival measured in months. So what we have been wanting is, in the same way as a FLT3 inhibitor added on to chemotherapy offered survival benefit for patients with FLT3 mutations, the question is, what can we do with targeting NPM1? And here there were late-breaking, interesting data presented on what's called the COMET trial. So this trial is of ziftomenib, which is a specific targeted agent against the Menin KMT2A pathway. This is a foundational target in AML. And basically, NPM1 and KMT2A, they target these drive overexpression of the HOXA9 MEIS1 genes. These are critical for AML proliferation, for transformation to AML, and then for propagation of the disease. And basically what ziftomenib is an inhibitor that is targeting this pathway. And this very important trial with late-breaking data showed some pretty interesting conclusions with activity. They were noting 45% overall response rate, 35% of the patients with complete remission. This was not a myelosuppressive agent. It's a single agent in this setting. Again, very frequently, these trials are initially developed as a single agent to assess their side effect profile and their overall tolerability before combination with other regimens. And here it was well tolerated. There was single agent activity, which we always love to see in a novel agent. There were durable remissions. And actually, what's particularly interesting is that resistance mutations were infrequent with this compound, which is suggesting that that is why it was able to retain its activity. I think that, so this is called the COMET-001 trial. This is a pivotal trial. It is actively accruing. We are anticipating and working already to move this agent into combinations. And again, NPM1 patients are treated with a variety of different combinations. Older patients have combination therapy with hypomethylating agents and venetoclax with relatively favorable outcomes compared to other subtypes of AML in the NPM1 setting. For younger patients, they are treated often with chemotherapy, sometimes with a combination of gemtuzumab ozogamicin. So I think there's really going to be an arms race to figure out how to take an agent like zifto, which is well tolerated and showing single agent activity, and how to incorporate that into the upfront therapy so that maybe we can prevent relapses of the disease. Relapsed AML is a dangerous disease. What we want to do is front load the therapy as much as possible so that patients never relapse. So I think these were two true highlights of the trial. I would say that they should both be watched. Gilteritinib in the active clinical practice setting. Again, it's an approved agent already, so we anticipate that this will result in wider application of gilteritinib in the post-transplant setting for patients with FLT3 mutated AML. And then for ziftomenib, the Menin inhibitors in general, and this one in particular, are a rising class of NPM1 targeted agents. Actually, NPM1 and KMT2A. KMT2A is also a dangerous pathway, which we are hoping that these drugs are going to be helpful in. But the development suggests that they're well tolerated, effective as single agents, and hopefully very combinable both with standard chemotherapy and with HMA and venetoclax backbones. Again, thank you for the invitation.